morning, everyone. So I'm presenting a case that was very challenging in terms of tricuspid valve intervention. Our patient is a 67-year-old gentleman who's post-mitral valve repair about 30 years ago. This was followed by mitral valve replacement in 2007, coupled with tricuspid valve annuloplasty. In addition, the patient's known for atrial fibrillation and complete heart block post-PPM. He also had history of recurrent GI bleeding and epistaxis. Preoperative echo had shown a normal ejection fraction, a mitral valve that's well-seated with mild paravalvular leak, and a gradient of 7 across the tricuspid valve with mildly dilated RV and mild to moderate dysfunction. On the left-hand side, we can appreciate the mitral valve discs moving well and thickening of the aortic valve with some mild AI. And we can appreciate the paravalvular leak on the 3D. This is the top Doppler across the tricuspid valve, and we can see a gradient of around 7 with a severe TR. When we came to know this patient, he'd been admitted with GI bleeding, significant drop in hemoglobin, and signs suggestive of right-sided heart failure. This continued for this patient for over 3 months. Usually, the patient was scoped, and usually these angiodysplastic lesions that were found are easy to manage. This was not the case for this patient, and we were unable to discharge him. So our issue and dilemma with this patient were the recurrent bleeding, inability to anticoagulate this patient with a mechanical bioprosthesis, and severe symptomatic TR. So the questions we had to ask ourselves were whether intervening for this valve is actually going to help us discharge this patient and help with the GI bleeds, and what are the risks associated with intervention. Our options were to do nothing, stay the course, or to offer this patient a tricuspid valve intervention. So the options as listed go from minimally invasive to maximally invasive, and I'll give it to Dr. Anas to give a few comments.
We can ask Dr. Anas to help us
evaluate
the options.
So we have a patient who has a Durand ring, which is a flexible ring. If you can just pull up my screen. So the 4 images at the top are actually of a Durand ring. So it's a flexible, incomplete ring in the tricuspid position. You have a permanent pacemaker lead through the tricuspid valve, which complicates imaging. You have severe TR, and then you have a mean gradient of 7. A mean gradient of 7, in this particular case, you have to be careful whether it's actually related to the tricuspid regurgitation in the context of a repaired tricuspid valve, or whether it's actually a true stenotic valve. So the option of tricuspid clip in this patient, I'm assuming I haven't looked at the whole TEE for this patient, but the imaging can be challenging. That's number one, especially in the context of a lead and a ring. If the TR was actually lead related, that would even add a second layer of complication that goes against the tricuspid clip for this patient. And then a third, and that would be difficult to differentiate before a procedure, the issue of the mean gradient of 7. So tri-clip may not be the best option. I still have to, we don't have the full TEE, but I'm assuming is not the best option here. The option of a trick valve, that's a possibility if the patient has anatomical suitability and they're not a candidate for any other approach. There is the option of a valve in ring. So a valve in ring in this particular patient with a flexible incomplete ring may not be the best option. Compare this to the second ring here at the bottom. That would be a physio ring from Edwards. This is a rigid incomplete ring. That would take a sapien valve. The problem with this approach is that in the area of where the ring is open, you do have 30% risk of having significant PVL, which you can manage with a plug if absolutely needed. And then you have the option of redo surgery. Redo surgery is also a good option if the patient was a surgical candidate. So if they were a surgical candidate and if the risk is not prohibitive, then that would be another way of dealing with this patient.
Thank you, Anas.
Yeah.
Let's go back to Dr. Bakr.
Okay, so in terms of risk assessment for this patient for surgical intervention, if you look at the isolated tricuspid valve replacement risk score, this places the patient at almost a 74% risk of mortality given the input data. This is coupled with the risk of exsanguination and bleeding on cardiopulmonary bypass.
1 minute, ya Ziad, please. Okay. If we can wrap up, Dr. Nouf, in a minute.
Yeah. Trick valve, not an option. IVC 41, this was not a non-CE marked valve, so it was not available in the kingdom. Triclip, we thought a high gradient, abnormal looking valve, so we did not go with that option. So next we're left with minimally invasive tricuspid valve replacement versus reduced sternotomy. In terms of reduced sternotomy, the minimally invasive offers less bleeding, a shorter pump run, especially if you're not doing dissection on pump, and can be performed on a beating heart without any ischemia time. This is our approach. So on your left-hand side, you can see peripheral cannulation, and these are the port sites and the thoracotomy. And this is from the aspect of the patient's leg. This is our setup. So just a note on whether there's something to support this. There have been a few retrospective studies that have looked at this and concluded that the risk is lower with a minimally invasive approach compared to reduced sternotomy in these patients. So that's it. Thank you very much.
Thank you, Dr.